Well, thank you. Thank you very much for coming. And I'm going to talk about a subject that I think is very near and dear to all of us as we start to get older. I'd say once you start to enter that fourth or fifth decade, you're starting to notice probably that some of the things you were doing cognitively, remembering stuff, paying attention, being able to remember when you get to the store what you came for, walking into a room and suddenly realizing you're not sure why in the room and you know you came in there for something particular, we start to all see the sort of the wear and tear on general cognition. And when I started in the field many, many years ago, I started with a particular focus on cognitive function and how cognitive function was related, of course, to cognitive decline and the development of dementia. And my work has evolved very differently to a whole different domain and really talks about how actually cognition and cognitive function with age can impact a whole range of behaviors, mood, anxiety, but not necessarily just always be an indicator that you're actually on a path to dementia. So the models that we have been working with for many, many years have typically been how do we track cognitive decline with age in order to predict who might develop Alzheimer's disease or who might develop a vascular dementia. So in my lab, and I'm very fortunate to have members of my lab here today, I have seen over, I'd say, 1,000 older adults come and participate in a range of studies across a decade of research. And of those, very, very few have ever developed dementia. It's a much smaller proportion of those individuals than you might anticipate. We're typically looking at numbers in the range of 4 to 6%. So it's actually, significant when you think at the population level. But for individuals coming into my lab, I had at least 35 to 40% who say, my cognition isn't as good as it used to be. And what we've started to discover is that this cognitive impairment, just this general wear and tear, actually can impact a whole range of functions. And that's what I'm going to talk about today. So now let's see with my own cognition if I can get this right. So what we do is we look at cognitive function from age 60 right through. In fact, the oldest participant in our studies was 102. It was actually the first female ever to attain a Ph.D. in economics in this country, and has since passed on, but was a wonderful participant for many, many years. And I would say that the message from the studies that we have done is that many people have what we would call very healthy, successful aging, where they remain very cognitively vital and functional for many, many years. In fact, the fastest growing work segment of the population is the over 85s. So that's a very interesting added to the workforce, that if you're over 85, that's the cohort that's actually increasing the workforce quite dramatically. And that might speak a little bit to people wanting to make sure that they have still money in the bank there, but it's also because people want to retain significant function past what was traditionally seen as 55 or 60 as when you might retire. So we look at a range of cognitive function over this lifespan and this particular span of 60 to 110 years. But we also have started to look at how cognition impacts mood and anxiety symptoms in late life. And this is a very new way of thinking about cognitive processing. So what do we mean by cognition? So the cognitive domains that we typically talk about as being impacted with age, and that term impact has a broad range of meanings, and I'll speak to that in a moment, are things like what we call executive function, your ability to plan, to sequence, to structure your day, to structure your activities, to balance your checkbook, to do everything from complex computer programming to just organizing a vacation. Your psychomotor speed. For many of you, I suspect, and myself, that's one of the things we start to see a slight edge off in our fifth decade, which is we're just not quite as fast to attain some of our goals, particularly when we're engaged in a cognitive activity as we were maybe in our 20s or our 30s. And it could be anything from that speed reading or cramming for an exam that we could do so well when we're young that you just can't do quite as well when you are actually 40 and 50 and so forth. Attention and inhibition are the two domains that in particular can actually be impacted in what we call typical aging. your ability to attend and also to actually inhibit other things that are ongoing at the same time. And not be distracted by those to the point that you can't pick up again from where you were. So you're watching a television show and somebody comes in and they start chatting to you, maybe hand you a cup of tea and you're watching, then you have to remember what was the plot and let me get back to that. And so inhibitory mechanisms whereby you actually rule out other distracting information certainly seem vulnerable to normal aging processes. Then we have the speed at which you process information, your working memory. Working memory is best defined, something that we don't rely on as much nowadays in the era of smartphones. But probably the best example of this is when you would have to call the operator, get the number, and remember it, a 7-digit number typically, and dial it after the fact. Something none of us have to do anymore. And it actually raises some interesting issues. Are we going to see an edge off working memory across the lifespan even earlier because people have become so dependent on externalizing mnemonics and things like their smartphone? You've got verbal memory, visual memory. Verbal memory is probably one of the things that most people feel is particularly bothersome when it starts to happen. So you start to have a situation where you're listening to someone tell you something like, please go to the store and get X, Y, and Z, would you pick up this? And you get there and you just can't remember what it was. You know you're supposed to get something, but you can't remember what it was. And that's probably a very fundamental example. We measure this with list learning tests, which actually assess the number of items you might learn. And it's certainly an area where any time has passed, we see some impairments over the later part of the lifespan. It's also the domain that's most impacted when you start to develop dementia. So that's when people start forgetting things, which is very normal with typical aging. They often get nervous that this is in fact a harbinger of something worse to come. And it often is not at all. In fact, in the vast majority of cases, it's just normal aging that we have to get accustomed to. There can be impairments in visuospatial ability, and actually, depending on the level of impairments, for dementia, we see that individuals losing their way, not being able to remember even simple directions or find their way home from when they go out to the store is probably one of the first dramatic signs that someone is at risk of a significant cognitive impairment. So these are the areas that we've been investigating over the years, and the two domains that are most fundamentally impacted as we start to age are what we call attention and retention, which is a simple mnemonic there. The ability to actually pay attention, inhibit, to divide attention, and then to retain information, particularly after any period of time has elapsed. And here this is a very fundamental basic slide on the parts of the brain that subserve these particular cognitive activities. So we have the prefrontal cortex, which is involved in executive functioning, information processing speed, and then what we call the medial temporal lobe or hippocampus, which is involved in working memory and verbal memory, occipital lobe and medial temporal lobe and visual spatial memory and visual spatial ability, and the motor cortex, which is involved in psychomotor speed. So there are a lot of brain changes with age. So any cognitive deficits, or your cognition is not quite as good as it used to be. My mother complains all the time to me. I complain to her. And basically that's subserved by changes in our brain. Brain is like any organ, it ages. And so what you're seeing across the brain is, with age and with every decade, is a little what we call gray and white matter atrophy. We also see an increase in what we call white matter lesions, which are little tiny dots throughout your neurons of white matter, hyperintensities, which actually usually indicate sometimes high blood pressure, or that you might be at risk for a vascular dementia based on maybe cerebrovascular disease. But the hippocampus, it's a very tiny region, and if I had the pointer, I would point there, but that little area that's red and green there is the hippocampus to the parahippocampus, and most of your memory function resides there, and hippocampal regions definitely decline with age. And so we have done many, many longitudinal studies that show that as people get older, those regions can in fact show some reduction in volume over time. The interesting thing is it's not always strongly correlated. with memory function. We have people who have smaller hippocampi than others and do very well in memory, and others who maybe have poor memory and yet they still seem to have an intact and robust hippocampus. So we're still really at the beginning of our understanding of the direct link here, but certainly this is the area of the brain that's most vulnerable in those that do develop dementia. And over the years we've identified some very specific genetic markers that have been associated with dementia, and those markers tend to be associated with a more rapid reduction in hippocampal volume. So there's no doubt that there are a range of physiological and brain abnormalities that occur that actually can lead to a dementia. What's interesting is many of these occur at much milder levels across the span of typical aging. So they're sort of divided into a range of categories. All of us actually lose neurons with age. There is actually a fairly substantial amount of neuronal loss. What's been very striking and actually very, I would say, heartening is in the last few years we see that the aging brain is also capable of what we call neuronal plasticity. There are all sorts of activities like cognitive training activities, cognitive enhancement, exercise that for the normal typical aging older adult can do a lot to actually even develop neurons. And we used to think that was not the case. Up to 10 years ago, you would have been told that actually there is no neuronal growth with age, but actually that's not the case. And we're seeing tremendous opportunity for neuronal plasticity. That said, there are very defined structural changes that occur and that can be mapped very clearly when we do these neuroimaging studies. So we see reduced hippocampal volume, which subserves memory function. We see reduced brain volume overall and increased in these things called white matter lesions and hyperintensities. And then some individuals seem to be more vulnerable to prefrontal deficits. That's where, in fact, the part of the brain that gets impacted most with normal aging is those areas of the brain at the front of the cortex which actually organize and control executive functioning. We also see deficits to areas like the anterior cingulate and the amygdala, which regulates emotion. We also see a fair amount of differences in neurotransmitters. Now, this is much harder to track because on the structural level, we've good techniques for measuring that. It's hard to measure the function in your brain of a neurotransmitter. A lot of this is inferred. It's inferred from PET imaging and from other studies, but we don't have a direct, really good way of actually understanding this. But we do know that disorders like Alzheimer's, for example, really show a profound deficit in the acetylcholine system, or we call it the cholinergic system. And that's why, in fact, the medications for Alzheimer's are in fact acetylcholinesterase inhibitors. There are ways of actually maximizing the amount of acetylcholine between neurons so that you can actually get better attention and hopefully by virtue of that better memory. But we also see deficits in other neurotransmitters that are not necessarily related to cognition per se. Serotonin is a neurotransmitter I'm sure most of you have heard about, and of course it is the key neurotransmitter associated with mood impairment. So people who feel depressed are typically thought to have a significant deficiency in at least the regulation of their serotonin. Probably one of the most challenging aspects of understanding brain function is knowing which aspect of serotonin is impacted. Is that somebody is releasing too much? Is it that somebody doesn't have enough for reuptake on the other side of the neuron to the next neuron? Is it that somebody just doesn't have enough cells, neurons that actually serve the serotonergic system? These are all things we're only started to chart now in this great era of, as President Obama would say, the brain, where really we're just starting to really get to a more fundamental understanding of these particular neurotransmitters and how they change with age and how they're associated with different disorders. There's no doubt that all of us will lose serotonergic function with age relative to our young adulthood. Serotonin is involved in mood, as is dopamine, but dopamine is also involved in such things as movement, and it's also involved in executive functioning. For a long time, we didn't realize that dopamine and indeed serotonin were neurotransmitters that were also involved in cognition. We tend to do our science in a very linear way. it makes total sense. It's very systematic. But if you're measuring cognition, you tend to focus on acetylcholine because that's the neurotransmitter that's most likely to be associated with cognitive processing. But if you're measuring mood, then you'll focus on serotonin. And if it's more movement and executive dysfunction, then you'll go with dopamine. And we don't do a good crosstalk between neurotransmitters and the outcomes. And that's one of the things that's changed in the last few years, and certainly that has been a prime focus of my work in my laboratory. And ultimately, if you're going to develop Alzheimer's disease, what we do see is neurofibrillary tangles and deposits of beta amyloid. Many of you will have heard about that. But if any one of you were to have an examination, if we could do that right now, most of us, by entering about the 4th and 5th decade, are already showing these signs of neurofibrillary tangles and beta amyloid, but it doesn't necessarily lead to dementia in all people. So it depends on the quantity, the amount, and it also depends on the placement in the brain. But the key factor is that all of the changes that are associated with some of the more severe impairments are actually evident in all of us at much milder levels. So as I was doing my work on cognition, I had expanded, by virtue of just working with someone in the field, to actually looking at depression. Now, late life depression is a very significant disorder and often underestimated. And I think part of it is potentially generational. Many of you in this room came from generations where it was not okay to say you were depressed. And not only was it not okay, it wasn't even something that was necessarily on your mind. You could be depressed without really knowing it. Being an Irish person and coming from a very different culture, I would say that actually we have a little bit of a similar slant. We don't talk about our feelings, our emotions. So actually knowing that we're depressed is quite difficult. We can maybe think we're just tired, or we're a little under the weather, and we're oversleeping, and we don't feel like doing all the things we used to do before, and not recognizing that those are key symptoms of a mood problem. The NIH states that late life depression is really a serious public health concern, and at least 2 to 3 million people over the age of 65 are impacted. But this is taking the most severe cases. If you were just to look at mild levels of depression, you would actually find the numbers much, much greater. And it's estimated recently, I have 6 million affected, but one recent presentation I just saw in Pittsburgh said it's as many as 12 million individuals. So it's not a normal fact of aging, and I think that's another problem, is that older adults feel, well, you know, my knee is going, and my knee is going, and there is, you know, I'm just not quite as energetic as I used to be when I was 40 and now I'm 60, but it's very easy to conflate and confuse what are actually depressive symptoms with what we call somatic symptoms of feeling just, you know, I'm just getting a bit older. So one of the problems is that it often manifests as physical symptoms when in fact it's a mood disorder, and therefore it's frequently misdiagnosed and undertreated. So over the years there's been an increased emphasis on, among people with depression, who are those who are most likely to develop a dementia. That's been the whole area of emphasis. So we started to think about, among those with depression, there does seem to be a subgroup who might actually go on and develop a dementia. And so a lot of researchers are investigating this. Executive function and memory certainly are cognitive domains that are impacted in depression. And greater severity of illness and also late onset of depressive illness are associated with increased impairments in a range of cognitive domains. Attention and memory recall are significantly impaired, particularly in patients who might have a psychotic presentation to their depression. And all aspects of memory and performance appear to be more impaired in the older depressed patient. So for a long time, I would say until 5 years ago, the emphasis here was on identifying those individuals with cognitive impairment among depressed older adults who were actually at risk for Alzheimer's disease. And after that, there really wasn't much consideration of cognition in depressed patients. And so then we started looking at sort of this physiological changes in an older depressed patient that were associated with cognitive impairments. And notice the huge overlap with the typical aging profile here. They're all the same things: impaired dopaminergic function, impaired serotonergic function. There also is increased glucocorticoids, which are a stress-related hormone, reduced hippocampal volume, reduced brain volume, white matter lesions and hyperintensities, prefrontal cortical deficits, all of the same standard brain changes that occur with normal aging seem to also occur in the older adult with depression, but to a more severe degree. Also, we noticed that patients in the literature, we were reviewing the literature, that if you had an executive dysfunction, problems with that attention and planning and sequencing, you were much more likely, even if you were treated successfully for your depression, to relapse. If you had memory problems, you were much more likely to have an increased risk of dementia. If you had problems with initiating activity and also with perseveration, perseveration is where you're going over the same thing again and again, there was more likely to be real impairment and disability if you were depressed. Also, it affects treatment, very significantly affects treatment, the level of cognitive impairment you have. So individuals who were depressed and had executive dysfunction showed a much poorer response to standard antidepressants like SSRIs. And the same with memory deficits. So cognition within depression, it became clear to us, isn't just a predictor of who's going to get dementia. It really seems to impact the course, the prognosis, and even the diagnosis. So it's a very, very important fact. And so what we started to think about a little bit was, to what extent does actually normal typical aging therefore put you at risk for the development of depression? So we'd seen the other side of the coin. You have a patient who turns up with a severe depression or even depressive symptoms, and they have cognitive impairment, we should track that. But what we started to look at is, if you have just normal aging wear and tear on your executive function, on your ability to inhibit and to pay attention, are you actually going to be more likely to in fact develop symptoms of depression? And that became something that we've become very interested in, because a lot of the older adults coming into our lab would have lots of symptoms of depression and anxiety, nothing that would ever reach the level of diagnosis, but certainly enough symptoms to be impairing on a day-to-day basis. So we started to look at this not just in depression, but in other disorders. So another affective disorder is anxiety. In fact, I would say that although anxiety is far less understood, my own feeling over the years is that anxiety is in fact as pervasive as depression. People get very anxious. They get anxious with age, they're anxious at all stages of the lifespan, and it's probably the least understood psychiatric disorder in terms of the source of that disorder, the cause of that disorder. So we have looked at a lot of studies that have suggested that in fact anxiety symptoms are also related to worse cognition in older adults. And there's some longitudinal evidence that in older adults with clinically significant anxiety or generalized anxiety, that they have worse cognition. But we said, what about just your standard typical aging older adults? So I do my studies on community-based elderly populations, often in this region, highly functional, very, very well-educated, often coming to our studies and participating. And so we looked at 95 older adults in the general area of Palo Alto. And they were 60 to 89 years of age, and they completed a range of these wonderful neuropsychological tests that we give people on everything from their memory to their information processing, to their mental flexibility, their inhibition, their verbal fluency, their naming abilities. That's the other thing, that when you get older, oh, you know the name of that thing. Who was it? Or that movie star, remember? And it happens all the time. We had a presentation, maybe I shouldn't say this on video, but we had a presentation today from our wonderful provost, Echemeni, who was at times saying, wait a minute, what's the word for that? And it's just something that becomes routine once I think you hit about your 40s. So we're all used to that. So we looked at that and we looked at how this was related to symptoms of anxiety and depression. Very simple scales that just ask you how anxious you are and how depressed you are. Now this is a rather cluttered slide, but I'm just going to give you the bottom line. The bottom line is for patients who just had anxiety symptoms, these would never be individuals or participants who would ever have a disorder, but they have enough anxiety symptoms. The big problem was in the area of inhibition and attention. That's where they were struggling. All around prefrontal executive function, inhibiting information out and actually dealing with speed of processing. For those who were depressed, it was a much more general pattern. There was a little edge off every cognitive function. So at this stage, what's very unclear is sort of which comes first. And so we have started for the first time to do some longitudinal studies to see, is it really that as you get a little bit of an edge off your inhibition and attention, which is very normal with age, that you're starting then to have some anxiety or mood symptoms because your ability to actually regulate your environment, particularly your emotional environment, might be impacted. So imagine you're having a stressful conversation and somebody else is talking to you at the same time, or maybe you're being harassed by some young person trying to get your parking space and you're trying to deal with that and take a phone call at the same time. Typically, those are kinds of things and activities where you need to have good inhibitory mechanisms. And what happens is if your inhibitory mechanisms are not actually doing well, it may be much more difficult for you to deal with the emotional components of the interaction. And that's actually one of the main hypotheses of our group at the moment. We are doing studies specifically to address that, because it would be very important, if that's the case, to actually keep your cognitive functioning in good stead. And there's lots that you can do to do that, because it would not only impact your ability to lead a healthy, successful aging and cognitive healthy life, but it may actually significantly enhance your ability to stave off depressive and anxiety symptoms. So at the same time as we were doing this work, and we would call this work behavioral, we're just doing these behavioral tests, we had a young gentleman arrive at the lab and arrive at Stanford to our group, who is actually looking at these particular emotional regulation mechanisms, how you regulate emotions in the brain. And he was looking at how different patterns in the brain were associated with different types of emotional regulation across a range of anxiety disorders. Now, I have to say, and this comes back to my Irish roots, is emotional regulation wasn't even a term we heard growing up, or indeed it wasn't even a term that was at the fore till very recently. We didn't quite think of emotional regulation. It's become a much more standard term in, I'd say, the last 10 to 20 years, that being able to regulate your emotions effectively is a very good way of keeping yourself in good mental health, as well as potentially now we're thinking cognitive health. Everybody has talked about emotional regulation from the beginning of time. If you read the wonderful Meditations of Marcus Aurelius, it's a form of actually giving you guidance on emotional regulation. Whether it's the Bible or whether you're reading the Tao Te Ching or any book that's actually giving advice in terms of how to live your life, or is a philosophical treatise, it actually is discussing emotional regulation in no small part. That's part of the components of some of those great books, whether they're representative of one's views or not. We have been trying to regulate our emotion since the beginning of time. And of course we see it in the movies with the penultimate Spock, if you're watching Star Trek, but all of the ideas that somehow retaining control over one's emotion is the ideal. We recognize the fallacy of a Spock, which is the sort of fallacy of false alternatives, but there's no doubt that healthy emotional regulation leads to better mental health and a reduction in affective symptoms, mood and anxiety. So he had been doing this wonderful work actually looking at this in younger adults. But what he wasn't doing was looking at the cognitive piece. He wasn't actually examining, in fact, was emotional regulation related to problems with cognition, particularly with inhibition. So we started to actually work with Dr. Etkin and to actually have a small pilot study looking at the ability of 18 healthy subjects, 65 and older, to actually engage in emotional regulation, and basically found that pretty much the same regions of the brain seemed to be activated, but that the older adults were almost identical in their ability to do this as the younger adults. So it was very interesting. Actually, there was very little age difference. But what was also interesting was that we started to deconstruct the relationship between the emotional regulation and inhibition, which had not been looked at before. And we started to see some evidence that, in fact, your ability to inhibit profoundly impacts your ability to regulate your emotions. Now, normally, if I was doing this presentation, I would show you the kinds of tasks we provide. But we're hoping that maybe some people might consider volunteering for this study at some point. And if that's the case, we're not going to actually preempt by showing you the kind of images that we display during the neuroimaging. So the key questions that we are discussing and that really our lab is examining have sort of changed how, even at the level of the National Institutes of Mental Health and other agencies, we're starting to consider the relationship between cognition and affect. We're starting to say not that cognition is just an indicator that you might be at risk for dementia, but that normal cognitive aging may put you at risk for poor emotional regulation and thus the development of mood and anxiety disorders. So our questions that we're now asking with a new study that we're engaged in is, are emotional processing and regulation associated with different patterns of impaired brain neurocircuitry in late life depression or anxiety? And is this dysregulation of emotional processing really due to impaired executive function or control during cognitive processing, not the other way around? Now, there are other factors that are also perhaps bridges between cognition and neuropsychiatric illness or even affective symptoms. There are the neuropathological features that I went over, the neurotransmitter deficits, but they're not the only culprits. Other things that we're investigating are, in fact, your stress reactivity. We have physiological measures of stress reactivity through the hormonal system of cortisol and its associated concomitants. We also are very interested in sleep disturbance, the wide range of sort of physiological disturbances that can arise from a poor night's sleep that actually may put you at risk for just being off your cognitive game the next day, and as a result of that, having more trouble actually inhibiting or regulating your emotions. So we're actually hoping to take the models that we're suggesting here and move them earlier down the lifespan to say, maybe for a child who is in a school situation and having behavioral problems, part of the problem with their emotional regulation or lack of emotional regulation is that they have disturbed sleep, they're cognitively sluggish, they're not inhibiting very well because they're tired, and as a result of that, they're not able to control themselves when they actually get angry or annoyed as effectively as they would. And we all know we don't do well on a good night's sleep. So we're looking at other bridges between cognitive function and affective function. So just to sort of recap here, and then I'll be able to turn it over for some questions. Why is age associated? Just very typical normal aging cognitive deficits, an important dimension in geriatric psychiatric disorders as well as in, just affective symptoms. And the traditional cognitive models have increasingly been employed as a window to understanding psychiatric disorders. We're seeing this much more. We're starting to recognize that cognitive deficits are a key symptom of such disorders as PTSD and schizophrenia. Cognitive dysfunction and neurocircuitry may play a key role, therefore, in understanding even the source or the cause of behavior and psychiatric symptoms. And distinct memory and cognitive deficits are increasingly being recognized as part of what we would call the broader phenotype of many psychiatric disorders. We know that cognitive dysfunction is a significant risk factor for the development of Alzheimer's disease. We know that cognitive dysfunction, if you already have a late life depression, puts you at increased risk for developing dementia. But what we're arguing is that cognitive dysfunction also may be a significant risk factor for the development of psychiatric illnesses, particularly in older adults where an edge is already going off the cognition. Cognitive and memory dysfunction may exacerbate psychiatric symptoms in all populations. And some of the work that we're now involved in, which is most exciting, is that cognitive dysfunction may in fact negatively impact response to both pharmacological as well as psychological interventions. So we just published a paper in January, actually, that contradicts this to some extent. We did a very nice study of cognitive behavioral therapy for late life depression. And these would have been individuals who spanned a spectrum. They were not all diagnosed with depression. They would have had maybe high levels of depressive symptoms, but that didn't reach maybe a clinically significant level. And they participated in cognitive behavioral therapy, which is a very structured way of making you think about your affective processing and dealing with, feeling down, feeling depressed. And what we found was very interesting. We predicted that if you had poor cognition, you would have a poor response to treatment. Well, we found that if you had poor executive functioning, you weren't doing that inhibition that well, particularly in inhibitory processes, it was exactly the opposite. You were a much better responder to CBT. So what we realized, that was very counterintuitive, and what we realized was that likely individuals who were having poor executive functioning were really struggling to organize, strategize, and therefore anything that was emotional on top of that was an extra burden. And by being able to provide them with a structure, in many ways CBT externalizes structure. It teaches you how to plan, to structure, to organize, to write down your symptoms, to have a plan for dealing with your symptoms. We are probably augmenting in many ways the performance of these individuals and actually treating them more effectively. So in fact, it was a better treatment response for those who were already cognitively impaired. So that was very, very exciting. What it also suggests is that there are mechanisms where you could go ahead of time and actually augment cognition in people who have a depression. There are lots of new cognitive training programs where you could a priori say, we're going to actually train you up, improve your executive functioning, and then see that you do even better with this treatment of CBT. So there's lots of different ways that you can go for this. The biggest bottom line, I would say, is that in fact, there are many good reasons for taking care of your cognitive functioning with age and many ways to do so. So to test our hypothesis overall that cognition really is subserving poor emotional regulation, because the other study was a treatment study related to cognitive impairment, we really want to see, is cognition driving the poor emotional regulation? So we have an ongoing study of 160 older adults for which we're currently recruiting, and there is 3 components, very straightforward study. There's eligibility, which includes measures of mood and anxiety, and we look for controls as well as individuals who would have mood and anxiety symptoms. We do a neuroimaging task. The neuroimaging task itself takes about 45 minutes, but it takes about 2 hours to make sure that everybody's settled, organized, comfortable. And then we do a neurocognitive test battery that tests a wide range of cognitive domains, from memory to executive function, speed of processing, naming. And then what? So the goal here is to see if in fact those individuals with mood and affective symptoms have actually worse cognition and therefore worse emotional regulation. And the next step would be then to say, well, if in fact this is the case, is there neurocognitive training that we can do that will improve, in fact, your cognitive function and thus your emotional regulation? Now, when I started 20 years ago, there was some very nice classes here at Stanford for improving your cognition as an older adult. It was a 2-week class that actually used what they called the method of loci, and you would actually have this really in-depth mnemonic that was trained. And we did some work on that and found it was very effective if your memory was already good. But if you're already struggling with your memory, it's not necessarily ideal to then be burdening you with actually learning a mnemonic. So one of the things that we've done over the years, and it's of all of this sort of intelligent technology and machine learning, as they call it, what you can now do, and what we're working on, is having batteries of tests that are entirely targeted to the individual, online in their home, that they sit down and do for 30 minutes a day, the equivalent of getting on your treadmill, and actually are specifically geared to improving you in the domains where you show some impairment and giving you some slack on the ones where you're already doing very well, as a way of actually augmenting and bringing you up to speed on a whole range of cognitive function abilities, but it's very much targeted to the individual. It's daily. And so this is kind of the wave of the future. So instead of having a 2-week course and hoping that lasts 5 years in terms of its effect, you would have a daily course that's targeted to you as the individual. So the next step for us is actually doing that. Having individuals who, when they finish our protocol, actually go into the cognitive training component, and then will subsequently come back 6 months later to see, in fact, if they are still maintaining good emotional regulation that's secondary to, in fact, improved cognition. So there are many things that can be done now. I mean, all the standards apply. People will say to me, you know, what about, does it help to do crosswords? Well, if you are good at crosswords, it doesn't do you any harm to do crosswords. It's probably not bad at all. But a crossword puzzle on a Sunday, even if it is the New York Times, is not likely to give you the augmentation for your cognitive function than a day-to-day exercise that's targeted to those domains that maybe aren't your strength. You know, it's interesting. It's very easy for people to accept this as a model surrounding exercise. You know, for example, that if you have been maybe a runner all your life and then you retire and decide you're going to walk around the block instead, then in fact, you're probably going to suffer, you know, some atrophy of your muscles, you're going to probably gain a little weight, you're just not going to be as fit as you were. None of us would expect to go from that level of activity to much less level of activity and not have some consequences. We also know very simply that to stay fit, we have to be active. But it's interesting, when it comes to cognition, we haven't yet grasped a similar model. So many of you would probably have currently or have had very active cognitive lives where you've had some jobs that were highly engaging and activities that are highly engaging and challenging and structured. And to suddenly give those up post-retirement and not, in fact, notice that that's an aspect of your life that you have to pay attention to is probably, you know, not ideal. And yet we don't apply the same models we would for physical activity to cognitive activity. So there's all sorts of different things that you can do. We had another study which we completed where we looked at autobiographical writing, a very popular activity for a lot of individuals post-retirement. They're very interested in writing about their lives. And then we did a structured 8-week course on writing. And people who engaged in the 8-week structured course on writing actually showed significantly more improvement in their cognition than the individuals who engaged in a more loose, self-paced autobiographical writing. And it was because they got feedback, they had to modify. It wasn't self-directed, it was receiving feedback. It was modifying your essay and have it here by 6 o'clock tomorrow. And that's a very different kind of cognitive engagement and cognitive activity. It's a little bit like having that personal trainer who makes you, you know, do that extra, 10 sit-ups. So there are models here that can be explored that we're still in the process of exploring. But I would say we're never at a better time for individuals maximally availing of, in fact, all that's around them to maintain strong cognitive health with age, and as a result, better affective health and mental health. So at this point, I'm, as an Irish person, always running over time, so we're now already close to 7:50, so I'm very happy to entertain questions on any component of this that you might be interested in.
Could you say more about distractibility? Because I find I forgetting things and all that, and I realize I'm not forgetting things as much as I go from one room to another and something catches my eye and I think, and then where was I? What was I doing? And that's really getting to be difficult.
So the question is to talk about distractibility. When I talk about inhibition, that's both failure to inhibit is actually easily distractible. And it's so interesting you should raise that, because for many years we really thought that memory was the key deficit with age. And everybody complains about that. Oh, I can't remember as well, or I have trouble naming. But really that ease of being distracted appears to be the most significant cognitive change with age. And it's specifically that component that we feel is related to emotional regulation. Because what it means is when a task then gets emotive, as well as having various distracting things, you're not able to extract everything out and focus on how to respond emotionally. You're still actually dealing with everything at once. And that's why we think for the cognitive behavioral therapy, I would say it's only in the last 5 years that we've really started to hone in on the importance of inhibition, the ability to inhibit out distracting information as a key component to potentially having less problems with mood and anxiety. And we're only starting to hone in on it as a key component of aging, typical aging that people are dealing with. So oftentimes we would have put down to memory deficits. This would have been seen as a memory deficit. You couldn't remember what you came into the room for. But it's not a memory deficit. It's a failure to be able to distract, to not be distracted by the ongoing. And if you have, there are studies that have been done in experimental psychology labs that show if you equate the level of distractibility from older to young adults, that those differences in memory and getting there and knowing what you did just disappear. So it's the distractibility is the problem. Another term for it was intrusion, thoughts that are intrusive, such as what they call totally unrelated thoughts. But again, that comes back to distractibility. Everybody has thoughts that are intrusive all the time. It's their ability to focus and keep focused on what's ongoing and put that aside that tends to be the critical factor. Yeah.
Is an individual who has suffered from anxiety from an earlier age, say 20, more likely to have cognitive impairment in older age?
That's a great question. So we just completed an Alzheimer's Association study that actually funded this, which was unusual because they usually only are very, obviously interested in the neurodegenerative processes. So that's absolutely the other critical question. We know that older adults with depression who have cognitive deficits definitely seem to be at more risk for developing, greater cognitive decline. We don't know this with anxiety, and part of it is because we don't have the longitudinal studies. So we just completed this study, we have the longitudinal data, and we're just analysing it and writing it up, and we are not able at any stage of a 2-year follow-up to tease the two apart. So we've no point where they're not coexisting. So they don't seem to be getting worse, but the coexistence between cognitive symptoms and anxiety is very strong. So then raises the issue for us. One of the things we're interested in doing is going back. Where does that start? How early in the lifespan does that start? And is this the case for people with anxiety from day one? So it's actually getting those sequence of which comes first is important, and it doesn't seem, the evidence that exists does not seem to suggest that in fact the cognition gets worse with age, with the anxiety. Gets worse with age, but not necessarily with the anxiety. Now, the one thing I would underscore, and I think it's really important, and it's often hard for us to come to terms with, is there is no single solution on any single disorder or set of symptoms. We tend to think, we'll one day find the solution. This happened when we actually had the whole genome. We're going to find the gene that was related to X, and it's just not going to happen. So for anxiety disorders, I would say that it could be a wide range of things, of which cognitive function may be only one component, and whether it's a causal relationship or just a co-symptom, so it's part of the same disorder. Things like physiological aspects, sleep, in older adults in particular, silent anemia, diabetes. There are a range of other factors that can produce symptoms of depression and anxiety. So one of the big challenges is knowing which is which when somebody actually comes in and says, I'm feeling very anxious, and is it something that was sudden onset? Was it always there? Is it related to your cognitive function? Is it related more to physiological factors? Is there an etiological cause in the brain? Is it more beyond the brain? And really, we're shockingly in our infancy and trying to come to terms and understand that. That's a big part of what we're trying to do. And I think the large databases that are coming down will help us to get to, much bigger data. People are nervous at big databases that are coming through with genetics, but I think we're going to get some of these answers quicker with these sort of larger databases. Yeah.
You kind of briefly touched on being an accomplished, highly educated, contributor to society. Then you retire, and
Precisely.
and then what? And kind of, am I getting that you're saying that you need a structure? But what do you do if somebody just keeps saying, well, what should I do? What should I do? You give them all these suggestions and then they don't do any of them,
Well, it's interesting question, because I would say that's a very pervasive question for people who suffer from affective symptoms more than even cognitive symptoms. So I think when people feel there's an edge off on their cognition, they're often much more likely to actually engage in the activities or try and do the things that improve cognition. Seems like we don't like for our cognition to actually not be, as effective as we would hope it would be. So I'll give you an example. One of the examples is there's a lot of evidence in the last few years to show that sleep disordered breathing, sleep apnea in particular, really has a negative effect on your cognition. And we do lots of studies on sleep in my lab, and we've shown a lot of this, published a lot on this. If you tell individuals that they're going to improve their life, their arrhythmia might go away, they're going to feel much better, they're going to feel less tired, they're not that compliant with CPAP. It's a very difficult thing to be compliant. You tell them it's going to improve their cognition, and indeed they may be even at risk for dementia if they don't do this, which is what in fact the evidence is showing. They're much more compliant. So I think it's interesting. I think it's harder for people, for those generalized symptoms, to actually sometimes engage. What I think is the difference and the problem when it comes to retirement is that if you were to say you were, say, somebody who was, really an athlete that was your whole day in, day out, you don't expect to go from that to nothing without thinking there will be consequences. But we actually all do that to some degree in terms of the post-retirement planning. Not everyone, some people are very mindful of this, but I don't think we have good models of it's important to keep that aspect of our life actually engaged and healthy, and whether it's courses that people take. I mean, there's an awful lot of colleges now. San Francisco State has an internal college specifically for people who have retired, where they go and take courses and have to get graded, and all sorts of people going back and doing their MBAs. I mean, those are things that would definitely keep you engaged. Not everybody has the facility to do that, but being conscious that being cognitively active, and the other thing is being physically active helps cognition. A lot of studies show that. Any other questions?
It would seem that retirement sometimes leads to depression. The person is used to being seen as contributing in a value, and then clunk, they're not.
Yeah, absolutely. And I think that's one of the areas where going from a sense of purpose, whatever that purpose is, to not having a sense of purpose is a critical contributor to depression. And that's at all stages of the lifespan. I think that's a big challenge for a lot of young people today who are struggling to find a job and so forth. So what do you do in that? Well, I often think that there are tremendous opportunities, particularly in this country, for people who have expertise and talent to give back. I mean, all sorts of volunteer opportunities. We have educational systems that often fail young people in certain socioeconomic groups, and being able to actually engage with Teaching America, which you can do at all stages of the lifespan. There's all sorts of ways to, I think, achieve purpose. And we encourage that for all our older adults. It's, if people are physically struggling as they get older, can often be hard to do. Internet is a marvelous way to do that now more, to engage with online programs that can help young children. There's a lot of ways to give back, but I think it's important to be conscious of the structure. There are no formalized studies on the structure of doing something. But I would say that when I see the older adults in my studies who seem to be very successful in terms of maintaining good cognitive health, they often have very defined structured activities that they have to do. And that applies at all stages of the lifespan. It impacts both cognition and affect. Yeah.
If a depressed person is treated successfully, does cognition
improve? That's a great question. Well, now that's a great question, and the answer is not necessarily. So, first of all, I mean, you know, we have a tendency, particularly when we're talking about the research and the questions we want to do, to emphasize the domains where much work needs to be done. That's why we're here. But there are tremendous strides in the treatment, particularly of depression. So, you know, the serotonin reuptake inhibitors were a huge significant advance that have brought a tremendous amount of improvement to many lives. And structured cognitive behavioral therapy and other kinds of psychotherapies have been wonderful for people. But there are still individuals who don't do well or don't respond well to treatment. In the current study that we just published on, it was very striking that although the response to treatment, when we had a fairly high bar that you had to reach, you really had to improve in your depression, it was the cognition that was the strong predictor, but the cognition itself did not improve. So that sets us back. Now, what's happening so is it just that the CBT was an externalizing, it's like its own form of mnemonic, it's a structure. And so actually the base cognition's not improving, but what's improving is the support system to help you manage your cognitive processing in the executive function domain. So, you know, it's no more than writing the list down before you go to the store. These are probably many ways that you have things that improve depression and anxiety by actually externalizing those cognitive domains that are impaired without actually improving them. And then the question becomes, if you improve the depression, do you improve the cognition? And certainly we've seen evidence of that. For individuals who actually come in who have pretty good cognition, but they're very depressed, they may even do better cognitively. So these are not necessarily people who would be 1 or 2 standard deviations below. They just have normal cognition, they're very depressed, and can go on either pharmacological or psychotherapeutic treatments. They can improve in their cognition because their cognition is now, they're freer to engage, and they had a higher baseline. So the baseline you were seeing wasn't as good in the first place. So it's a very complex story, and one that's taken us a lot of work to tease apart. We have some flyers at the back that describe the work of the lab. I have great people, Isabel Jolie here and also Josh Tall. And what I would say is if you have any additional questions, because I know we're at the 8 o'clock hour, I'm extremely happy to respond to emails, to answer your questions. This is what we do. This is the part where we try to give back. We get a lot of investment in our research from tax dollars from you guys, so we want to be accessible and approachable if you have questions at any time. Thank you so much for listening.